Welcome, everyone. My name is Beckie Child, and I am a professor at Utica University. And I was really excited to see this conference come about because I just defended my dissertation on this topic. And so I'm going to be sharing with you the results of my research for my dissertation. And I just want to say I've so appreciated listening to other speakers today and the things that they've mentioned. I'm really honored to be part of this seminar. Also, just a note, I am recovering from COVID, so my voice may give out periodically, but I'm so much better than I've been, so I'm grateful for health too. So let's get started. So to tell you a little bit about me is I am a person with lived experience of a psychiatric disability. I've been dealing with it most of my adult life. I also came to social work through advocacy. It started out, I was a pretty horrible advocate for myself. I was never very successful. But when I saw other people being harmed, I honed my advocacy skills, and I spent more than 20 years doing individual and systemic advocacy to try and make the mental health system better. And then eventually I found my way into the MSW program at Portland State, and subsequently the doctoral program as well there. And so it's with this perspective that I approach my research. Oops. So you all may have seen this slide lots of times, but I just like it. It's a great summary of current literature. And one of the things that I really a little bit take issue with is the less likely to follow treatment. And it just makes me think about the structural barriers that make it more difficult to follow treatment rather than them being less likely to follow treatment. So that's just a thought that I have about that particular slide. I focused on the lived experience aspect of receiving mental health services, in part because several years ago, I was asked to develop a curriculum to teach people with psychiatric disabilities how to talk to their doctors about medication concerns. As a result of that experience and developing a mini education course on that, I became interested in health literacy, and then was asked to consult on a project that was being developed through SAMHSA, and was really disappointed that it was dependent on so much pen and paper when the literacy levels are what they are. And I was just, so I just wanted to figure out other ways to present information to people to make it useful to them. And when I started looking at the literature, I only found one article out of the thousands of articles that have been written on health literacy that actually talk to real people. And that really bothered me. And so the other issue that comes up for people with psychiatric disabilities is that they deal with both physical and mental health challenges simultaneously. And our healthcare systems are set up pretty much that you have to address one in one part of the healthcare system, and in a completely different part of the healthcare system, you have to deal with the other. And even though they keep talking about integrated care and integrated healthcare, I still find it really interesting that the health outcomes really haven't changed all that much, at least in where I live. And I live in Portland, even though I teach it in New York. So, so let's talk a little bit about the health literacy definitions. In 2016, Malloy Ware and their colleagues identified definitions of health literacy. There were 6 that were most commonly used. There were 133 variations of the 6 most commonly used definitions, and there were 111 other definitions. So as thinking about this study, there's the saying that it lives within the psychiatric disability community and other communities as well, about nothing about us without us. And I chose not to use the definitions in the literature because they weren't built with input from people with psychiatric disabilities. And so instead, this was a definition that I used in my research study. So health literacy is a concept that describes the skills, information, and knowledge one needs when making medical decisions. And so that's what I used. These were my research questions. And I was interested in barriers and facilitators of health literacy for folks with psychiatric disability. And how does health literacy impact people with psychiatric disabilities in both physical and behavioral health care? I have to say, I was initially discouraged from trying to address both physical and behavioral health care. And because I decided to include an advisory board of people with lived experience, they pushed back on that and said that it was really important to address both in my research. And then how can healthcare providers address the health literacy needs of folks with psychiatric disabilities? And those were the questions that guided my research. So I already mentioned the advisory group. I did a small qualitative study of focus groups with a small quantitative survey. There were 4 focus groups and 1 individual interview. I used purposive sampling, which means that people had the purposive sampling was that people had either currently used or had used public mental health and public health services, so basically funded by Medicaid or other general funding sources. My participants were between 18 and 64 years of age, and they have or had a mental health diagnosis. Excuse me. So these are the descriptions of my participants. So I had 19 participants that consented, 14 that completed the survey, and 13 that actually focused or participated in the focus groups and the individual interview. Most of my participants were self-identified as white females. I did have one person that identified as Native American female, one person that identified as a Black female, and one person that identified as having more than one racial or ethnic identity, and one self-identified white transgender male, and 4 white males. So my participants had, 2/3 of my participants had a bachelor's degree or higher education, which is really unusual in a public, in a Medicaid-based service. Most people don't have that high of an education level. And I found it really interesting that 9 of the 14 participants reported that they still occasionally or sometimes had difficulty understanding written documentation. And that nearly half of the participants had at least some difficulty reading hospital materials. And that most participants were confident completing medical forms by themselves. So there's a little bit of conflicting information here, I think, and maybe it's just that there's differences in the tasks that makes some things a little bit more difficult than others. In the qualitative research, one of my participants talked about how she didn't know as much as she thought she did about physical anatomy. She was having a hysterectomy, and she said the doctor did a really good job of explaining the procedure. But what she realized after the surgery had taken place is she didn't know where her uterus was in terms of her body and what that meant for her recovery process. And it was a longer process because they were not able to do, and I just lost the term. Is it laparoscopic hysterectomy? My apologies if I've got the terminology incorrect. But they had to cut her open, and it really did do a number on her and her recovery process. Um, Also, I think because the participants had a higher education level, they didn't really specifically address traditional aspects of health literacy, like reading and understanding forms and things like that. Um, and then also they did discuss how living with mental health and physical health conditions simultaneously affects them. And they talk about um, our physical health affects our mental health. So the worse is the or better it is, the worse or better our mental health is. Um, and, and then also health literacy is relationship based. Participants talked about when they're treated with respect, that makes it feel like you can ask questions. Um, and talking about if you have a primary care provider who's an advocate, it will seem like somebody has a friendly face. It's nice to see a friendly face when everything else is falling apart. Somebody that you trust, somebody that's on your side, somebody that's willing to be patient, somebody that doesn't get frustrated easily. So some barriers to health literacy is this term called diagnostic overshadowing. And this term originated in the intellectual disability field. And it's the idea that whatever healthcare problems somebody may be having, it is not actually anything to do with their physical health care, but due to their diagnosis. This also plays out for people with psychiatric disabilities. One participant said here, so many doctors don't pay any attention. In multiple emergency rooms, she was misdiagnosed with kidney stones for 8 months. Can you imagine having a kidney stone for 8 months and that nobody found it or listened to her? They kept giving her antibiotics after antibiotics, thinking I was being overdramatic because I had anxiety and because whatever. She was really upset about this. Nearly all of my participants had received peer specialist training or peer wellness specialist training and were employed as peer specialists or peer wellness specialists. And their length of employment was how long they had been doing the work, not necessarily for the same organization, was from anywhere from 1 year to more than 20 years. And the participants are highly educated. I mentioned that already. Another thing that I learned from this was that people make meaning from their stories. And the method I use to do my analysis, content analysis, is not well suited for use in giving voice to people's stories. So the implications for research, there is a need for more lived experience research on health literacy with more traditional users of the systems. We need to co-create knowledge and policy between people with lived experience and social workers and other healthcare providers. And we can partner and share power with people with lived experience in exploring health literacy through an ecological framework that includes kind of looking at their entire environment. Some other things that I learned from the health literacy research is that in almost every study, including my own, I'm not exempting myself from this, we only measure health literacy one time. And that kind of implies that health literacy is static, and it's not. People who hear voices or have diagnoses of what we call schizophrenia or schizoaffective or bipolar disorder, that their health literacy changes depending on how active their symptomology is. People who are experience interpersonal violence and this tremendous stress that puts their entire existence into overwhelm, their ability to access information when they're that stressed compared to when they're not under that kind of stress is very different. People have strokes and other healthcare problems that change the way they need information presented or how they understand information. And we need more narrative and multimedia research that listens intently to people's stories. Um, and there really is no health without mental health, and no mental health without physical health. Um, and we need to think about that as we're trying to improve our programs and address the health inequities within the mental health and the healthcare system. One of my participants talked about how when she was in labor and she had opted to do a water birth, but she had preeclampsia, and they shuffled all of her support, her mother and other people that were there to support her, out of her room, and her anxiety level went off the charts. They refused to address her anxiety or answer questions. She really didn't understand what was happening at the time. And she says if they would have just listened to me and let me have one person in there to support me, I probably could have dealt a whole lot better than what I did. The other, again, going back, that health literacy is dynamic. It's not a point in time construct. Another issue that came up in my study is that self-advocacy is not without risk. People can get retaliated against by well-meaning people, and not necessarily malevolently motivated people, but it does happen. And so identifying strategies where you can group people together to self-advocate together, because there's less risk in a group than there is when you do it one-on-one in terms of trying to confront power structures and structural inequities. So some of the themes that came up in my research were coercion and lack of choice. This was a big deal in the themes that were developed. The lack of trust, as you can see here. Now you notice these three items here that have codes. This just means that that this was a latent theme, which means that it's one that I had to do a little bit of interpreting of what was said to come up with this theme. These others are pretty obvious in the transcripts when they talk about having a lack of credibility, or they talk about having a lack of trust or feeling disrespected. And then this other one that seems to be a big focal point for a lot of people is the emergency department. For people with psych disabilities, this is a really dangerous place for them in terms of iatrogenic harm and not getting needs met for folks with psych disabilities. So there's a lot of work that needs to be done here. And then in terms of facilitators for health literacy, or is having positive long-term relationships with a provider. And in some places, the provider churning rate is pretty high, and it's and then we wonder why people don't want to trust us when you're going to leave in a few months, or for people who've experienced a lot of adverse relationships in their background, trying to develop a positive long-term relationship with their provider is a must. Trust and treating people with respect, listening, asking questions, and self-advocacy, and then building comprehension and understanding. That was the other interesting piece that I found, was that when people have positive relationships with their providers, that they can help build comprehension and understanding with their patients. And because it sets up an environment for learning. And excuse me. So before I go to questions, the other thing I wanted to say is I think, well, one, I just got notified of an article today by the researchers from Australia, Dr. Osborne and others, talking about how we need epistemic injustice, where we give credit for only certain people's knowledge, and a lot of people who are disadvantaged or come from a non-Western European background we don't give credit to them for the knowledge that they have. And that article really excites me. I can't wait to dive deeper into it today, because I think it matches some of what my research said. The other piece I would say um, is that, and it just slipped out of my head. Give me just a second here. Oh, I think it decided to go on a permanent vacation. Yep, I lost it. It might come back in a minute. So why don't we take some questions? Oh, and I want to say I've made my slides. I sent my slides to Mario. And Mario, it's the second set of slides I sent you. There were some errors on the first set, so please share the correct slide. So yeah, so people with psychiatric disabilities who've spent any time in the hospital can feel coerced in a number of different ways. One is through forced treatment. So if you have people uh, who are being force medicated, or on a notice of mental illness, or some way where they're not able to leave the hospital, that feels like coercion to them. And that can interrupt health, be a barrier to health literacy, because they're not going to trust a lot of the providers because they feel they shouldn't be there. And they didn't specify certain medications, but I do know that for some people, when they are given the once monthly shots, that or however long they last now, I'm not up to date on medication as much as I used to be. They that feels like a form of coercion to them as well. And let's see. Yeah, long-acting injectable antipsychotics. Thank you. And some people on those long-acting injectable antipsychotics like it because they don't have to think about it anymore. But again, that's where you want to have a conversation with somebody about how they feel about it, and realize that their feelings may change over time. And maybe as they get better, they want to be more in control of their life. I'm not sure I understand the question, like how does a person advocate to not be on meds without feeling coerced? I don't know if I can answer that question. Sometimes it's one of the things that I really enjoyed when I was taking medication is that my doctor and I, we had an agreement about if I was having more symptoms or more distress, that I could up a dosage of one of the medications I was taking. So there was some flexible dosing that was left to me. That's a tool. I don't know if any of you have, I'm sure many of you have heard about Pat Deegan's Common Ground program. That's an amazing program to help people understand why they're taking the medication they're taking, how it's supposed to help them. I mean, that's the other thing that I really got from the study is in mental health, we do not explain hardly anything. So many people said they didn't know why they were taking the medication that they've taken, and what it was supposed to do. They're just supposed to take it. And so many times when I know in my own experience, I went in and was telling my psychiatrist that periodically I would have 2 or 3 days where I was like hypomanic. It only lasted for 2 or 3 days. But and so I was having this, what I thought was a conversation. And instead what he did was he pulled out his prescription pad and wrote me a prescription I wasn't asking for another medication. I just wanted to give him some information so that we could watch. In other fields of medicine, they talk about watchful waiting. So how could you do watchful waiting? What conversation are you going to have that says that, oh, maybe I might need some help, or a little bit more help than what I thought? And how do you make that so that's a safer conversation to have and not feel like you're going to be threatened with involuntary hospitalization or some kind of hold process? Um, the program is called Common Ground. If you type Common Ground into the search engine of your choice, it will come up. Pat Deegan is the researcher who is behind that program. And she has two programs, the Common Ground one, and it has all kinds of videos that help people talk about some of the hard things to talk about when it comes to medication in their life. But one of the things she talks about is having power statements and having people write a power statement. So say a mom who is a single mom and she's got 3 little kids. She can't afford, in order to be a good parent, to have a drug that sedates her in the morning. And so maybe she writes a power statement that says, I want to be a good mom for my kids. All right, well, that gives the doctor information. I mean, how many times have you heard a conversation between a patient and a doctor? Hi, how are you? Fine. What's been going on? Nothing much. You can't get any information from that conversation. And so having people focus on a power statement, what is it they most want to do? And for maybe some people who are struggling and having lots of symptomatology, that might be a really hard task to get them to figure out what their power statement is. But she has videos that provides examples. You know, maybe there's a young man who wants to have an active sex life, and the meds are affecting his sex life. That is a really hard topic to talk about. So how do you talk about that when you're embarrassed to talk about it? And she has some strategies for that. How do you write a statement that I want to have a girlfriend? I want to be in relationship with somebody. So those are some of the tools that she uses. And the videos, and her videos are appropriate even for young kids that are taking medications, and talking about informed consent and knowing the importance of knowing why you're taking what you're taking. Excuse me. If you search YouTube and put in power statements and Pat Deegan, she's got a couple of videos in there about power statements.
Becky, could you talk a little bit more about other types of ways to address, you know, the distrust, or tools that can be used in the emergency room, you know, just other types of interventions for the patient?
Okay, so let's talk about the emergency room. So what happens when somebody comes in? Maybe they're initially presenting with a mental health disorder or something that's in an acute stage. What is the experience of that person? You put them in a room by themselves. Many hospitals or psych emergency rooms have them dress in, get out of their street clothes and dress into scrubs. I understand there's some safety concerns in there, but couldn't you let them have their clothes back after you search their clothes for any potential harmful material, and let them have their dignity back? You know, having peer support workers in the emergency room. What's the name of it? The Rose House in New York, Steve Michio and People USA has a respite program for folks who are in needing of more acute support, and it's as a diversion to hospitalization. And they talk about giving people space, and they've also started putting people in the hospital to support them while they're there. So they have somebody to talk to that can explain what's going on and why they have to do this or why they have to do that. Um, and they can share the fact that they have lived experience, that they have something that they can share that lets that person know they're not alone. Steve shares a story of a man who came into the hospital where he was working in the emergency room, and he came in carrying a glass of water. Now, for those of you who work in hospital emergency rooms or have a lot of experience in those areas, what is the most likely scenario that's going to happen in most hospital emergency rooms? If he's not willing to give up that glass, there's most likely going to be a takedown of some sort, which causes trauma. But what this man was saying was that this was his soul. And so what he did, so Steve said to this man, well, then you better take good care of it and keep it safe. And he ended up getting it. Oh, so the doctor went in to talk to him, and the doctor comes out and asks Steve, what do you think? He says, I think you need to go back in and talk to him, because he didn't think he had spent enough time talking with him. And so he went back in and talked to him again, and he came back out, and the man ended up getting admitted. And the next day when Steve came back to work, he went up to check on this gentleman, and the glass was now empty, and he says, by the way, I don't need this anymore. He gave the glass up. Let's see. I think my chat scrolled.
Thank you, Becky, for that
Yeah.
response.
Yeah, Steve does presentations everywhere. If you it's People USA is his organization, and he's more than willing to come and work with your organization to help you move to more person-centered and person-directed ways of supporting people. I know that a lot of people use WRAP plans, the Wellness Recovery Action Plans. Having those plans in place, asking people, what is their WRAP plan, and trying to support them through the active use of that WRAP plan is really a great tool too. Any other questions? Well, we will start the next presentation in about 5 minutes.
Thank you. Thank you, Becky. Great presentation. And in the next presentation, we'll talk a little bit more about pharmacy and health literacy. Thank you.
Thank you.
Bye.